Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I have a very interesting topic. It's actually a lecture that I put together based on my experience and the teaching I got back in fellowship. I put it together a few years ago and have given it many times before, got great feedback on it. So I thought I would share it with you. And it is basically my approach to the sick infant in the Pediatric Emergency Department. Let me just start with a disclaimer and say that this talk or this presentation is not necessarily based on any specific research articles. It's based on the education I got in fellowship from my attending. It has worked for me over the years, and that's why I keep using it, and that's why I also teach it. Starting with pediatric emergency medicine specific advice. My advice to any of my residents or my medical students who are going into pediatric emergency medicine, when you see a sick infant or when you resuscitate an infant or any child for that matter, have two things by you. Number one, have the parent by the bedside. And that has essentially two reasons. Number one, I always want the parents to see that we as a team are doing everything for their child. Number two, many times the parent is an excellent source of history, and that can really help you do the right thing for the patients. So things like knowing that the patient takes steroids chronically can really play a huge role in the resuscitation of a patient. Knowing that the patient is taking seizure medications or what they are, or if the patient just had a medication or some kind of an allergic exposure right before arriving in the ED. So having a good source of history is very important. The second advice I give all my trainees, always have the IO, also known as the intraosseous, by the bedside. My nurses are excellent in getting IVs, but sometimes it doesn't work, and having that IO in front of my face just reminds me I can get access very fast in case the IV doesn't work. I'll be honest, in the past, when the IO was not right there in front of my face, I didn't forget about it, and there were delays in getting IVs, which do not serve to the best interests of the patient. Now again, my approach when I walk into a room and there is a sick infant or an ill-appearing infant, by that I mean a child, an infant that looks very lethargic, maybe seizing, maybe altered mental status. The word sick is obviously very broad and can mean many different things. Whatever it means to you, I think that's fine. When I walk into a room and there is what I think is a sick or an ill-appearing infant, in my differential diagnosis, I immediately think about the following 5 things. Number 1, sepsis. Probably the most common, but the one that is hardest to resolve in the pediatric emergency department. Number 2, congenital adrenal insufficiency, which is actually a lot more common than people think. Number 3, congenital heart disease, first presentation of. Number 4, metabolic disease, also known as inborn error of metabolism. And number 5, non-accidental trauma. And those are the 5 things that come into my mind when I see an ill-appearing or sick infant. Now I should probably say that I'm talking about an infant that was previously well and an infant that does not have any significant past or perinatal history. Clearly, if the child has a known metabolic disease, the issue is a lot easier and the workup is very, very algorithmic. I'm talking about an infant that, according to mom and dad, was previously well and does not necessarily seem in respiratory distress, which is probably one of the most common reasons I see a sick infant, bronchiolitis in the winter, for example. Now, because those are the 5 things or the 5 first things on my differential diagnosis, I consider the following 5 studies as my best friends. In my experience, with using those 5 in that specific order, I can usually figure out what's going on or at the very least get a direction and do what's best for the patient. Number 1, ISTAT, otherwise also known as point-of-care electrolytes, knowing the sodium, potassium in very few seconds. Number 2, point-of-care glucose, also known as AccuCheck in some places. Number 3, a chest X-ray. Number 4, an EKG. And number 5, CT brain/CT head without contrast. It is my experience that with those 5, I can usually get a direction of what the child has and do what's right for them, and I specifically put an emphasis on the order of those tests. The reason is because I think it makes no sense sending a child to CT brain to see if the cause of his ill appearance is head bleed without finding out the sodium, the potassium, and the glucose, and potentially have a hypoglycemic patient in the CT scan. So I do my iStat electrolytes, my point-of-care glucose, chest X-ray, EKG, and CT head in that order. I need to make sure the patient is not hyponatremic before he gets to the CT scan. I need to make sure the patient is not hypoglycemic before I order a chest X-ray and wait for the technician to do the portable chest X-ray. I also need to recognize that I can treat sepsis or congenital adrenal hyperplasia, and I cannot really definitively treat a patient that is ill appearance from a head bleed due to abusive head trauma. Unfortunately, I can't also really help the patient with congenital heart disease. He really needs a surgeon. So I therefore obtain those studies in that specific order, given my capabilities to reverse the situation as a medical non-surgeon physician. So again, to summarize, when you see an ill-appearing or sick infant, whatever that means for you, think about the following 5 diagnoses and think about those tests. Number 1, sepsis. Number 2, congenital adrenal insufficiency. Number 3, congenital heart disease. Number 4, metabolic disease. Number 5, non-accidental trauma. And the studies or the tests I perform as soon as possible are the iStat electrolytes or point-of-care electrolytes, point-of-care glucose, chest X-ray, EKG, and CT brain or the head without contrast. I would like to discuss each and every one of those diagnoses, what I do for them, what I think about, and I focus on what will kill the child and I can change it right now. So starting with the first one, sepsis, usually those patients present with hyperthermia, also known as fever, or hypothermia, which make things a lot easier. I think it's very unusual to find a child with sepsis who actually is normothermic, so that certainly makes things easier. When I think about sepsis, I think about the fact that in newborns and infants, fever can certainly be a presentation of a systemic infection, and if the child is ill-appearing, local infection is probably not on the differential diagnosis today. I think about giving antibiotics and giving antibiotics early. But I certainly recognize that serious criteria are not particularly specific in newborns or in babies or in kids to that matter, and 93% of febrile patients actually meet serious criteria. And when I think about sepsis, I think about what will kill the child now, and I can reverse it. So clearly, when talking about sepsis, we worry about septic shock, and in order to fight shock or septic shock, I need to maintain the patient's cardiac output. Now, taking you back to your medical school days, I remind you that cardiac output equals stroke volume times the heart rate. Kids are very good in maintaining heart rate. They become very tachycardic and tolerate their tachycardia very well. So it's basically my job to control the patient's stroke volume. Stroke volume is affected by preload, afterload, and contractility. Controlling the preload is something I, as a Pediatric Emergency Department physician with IV access or IO access, can do very well by giving fluids. So giving fluids early and liberally if I suspect a septic shock is very, very important. Again, PEM rule number 13 says that the only way normal saline can kill a child is if he drowns in a pool full of it. Certainly that is some exaggeration, but not a very big one. Kids tolerate fluids very, very well. It's extremely rare to cause pulmonary edema for a normal healthy child who's in septic shock. So if the concern is septic shock, give fluids liberally. Also keep in mind PEM rule number 15 that indicates that a bolus over an hour is an oxymoron. If you think the patient has shock or septic shock, give fluids and give fluids by the push-pull method as soon as possible. Now, as far as the antibiotics, again, we do know that with septic shock, giving antibiotics early can really change the outcome and save a life. So I think about the patient's age, and if the child is younger than 28 days, I usually use ampicillin and gentamicin or ampicillin and cefotaxime. If the child is over 28 days of age, I give ceftriaxone, sometimes ceftriaxone with vancomycin. Again, if I suspect MRSA of any sort or resistant pneumococcus, which unfortunately has become a problem. Moving on to the second thing on the differential diagnosis, congenital heart disease. Again, from a pediatric emergency medicine standpoint, I think it's important to keep in mind and be humble. There are just too many to think about. And the further I am from my residency, the harder it is to remember all those congenital heart diseases, which one is cyanotic, which one is not, etc. But I try to keep things simple. I try to keep in mind that unfortunately, if the cause of the ill appearance is a congenital heart disease, I will not be the definitive care today, and unfortunately, there's not a whole lot I can do, which is also the reason I don't check for that right away. And because congenital heart disease is on the differential diagnosis, EKG and chest X-ray are next to be performed. I consider EKG and chest X-ray as my poor man's echocardiogram. Again, I only perform those after I make sure the glucose and the sodium and electrolytes are within normal limits. Now, if I think about what will kill the child who's suffering from a congenital heart disease, it's probably a hypoxia that can lead into cardiac arrest. This is where physical exam comes into play, making sure the patient has good peripheral pulses, perfusion, skin color, peripheral blood pressure, etc. And again, using that EKG and chest X-ray as your poor man's echo. We all know that with congenital heart disease, a chest X-ray can be very helpful by finding certain heart shape that are unusual, like the boot-shaped heart or tetralogy of Fallot, etc. I also look for vascular congestion to indicate heart failure. Blood casts can be helpful later on, as well as talking to cardiology early. Again, I always teach my residents, it's important to know what you don't know, and if I truly suspect congenital heart disease as the cause of the ill appearance look of this baby, talking to the specialist can go a very long way. In terms of what I do for those patients, I try to ensure adequate ventilation, give oxygen, cardiorespiratory monitoring with frequent blood pressure is very important, and again, checking those electrolytes, which I already did, specifically the sodium, because as we know, kids with heart failure can be hyponatremic. I've actually had seen that in the past, unfortunately. I try to think about treating pulmonary edema early with diuretics and or morphine, and again, calling the pediatric cardiologist early. Bearing in mind that there are many congenital heart disease and subtypes of those congenital heart disease, so talking to the specialist early to help you manage that patient can go a very long way. Now, my biggest advice to my trainees and my residents with regards to managing what you think is a congenital heart disease issue is that with any newborn with sudden circulatory collapse, be it hypoperfusion, hypotension, cyanosis, whatever it may be, I really should consider a ductal-dependent lesion and make sure I give prostaglandin or at least entertain the possibility of it, because prostaglandin can provide rapid stabilization of a patient who has a ductal-dependent lesion which is slowly closing. Now, if I give prostaglandin, which I've only done once in the past, you gotta remember that unfortunately apnea is a real and significant possible side effect, so intubating that patient early is probably very important. So again, any newborn with sudden circulatory collapse, hypoperfusion, hypotension, cyanosis, who was fine before that, the possibility of ductal-dependent lesion should be entertained, and giving prostaglandin early when intubating the child because of the apnea can go a very long way. Moving on to the third diagnosis on the differential diagnosis, congenital adrenal insufficiency. So congenital adrenal insufficiency is actually more common than people realize. It's about 1 in every 15,000 births. The prevalence varies according to ethnicity and geographic area. And again, thinking about what the problem is. So if you have a dysfunctional adrenal gland, you will have no sodium reabsorption, which will cause hyponatremia. You will have no potassium excretion, which will cause hyperkalemia, and that can be very bad and very dangerous. You will have no gluconeogenesis, and the patient will be hypoglycemic. So again, thinking about what will kill the child, and I can reverse it. Certainly the hypoglycemia can be a problem. A lot of times, kids with congenital adrenal insufficiency due to the lack of cortisol can die from shock or hypotension. As we discussed, hyperkalemia can be a very big problem. And hyponatremia, I'm not sure is actually going to be lethal, but certainly does not contribute to the ill appearance child. Now, in terms of intervention, normal saline bolus as soon as possible is probably the most important step to do, and possibly all the patient needs. A normal saline bolus for a kid with congenital adrenal hyperplasia can do several things. Number one, it corrects the acidosis and therefore the hyperkalemia. You probably remember that those are unfortunately associated with one another because when you're acidotic, the body takes the hydrogen into the cell in exchange for potassium out of the cell, causing hyperkalemia. So again, correcting the acidosis can fix the hyperkalemia. It also dilutes the potassium concentration, which also improves the hyperkalemia. It reverses the shock or the hypotensive state, and it improves the hyponatremia since normal saline bolus is 145 or 146 milliequivalents per liter. In terms of the treatment of hypoglycemia, I try to keep in mind the rule of 50 to 100, which is my simple way to figure out how much glucose or dextrose I'm going to give the patient. So the rule of 50 to 100 states that in order to correct hypoglycemia in a child, the amount of dextrose I have to give multiplied by the cc per kilo I have to give equals 50 to 100. So for example, in my ER, you can get D5 pretty quickly. So D5 times 10 cc per kilo, 5 times 10 is 50. That's great. You can also do D10, 10 cc per kilo, 10 times 10 is 100. Or D10, 5 cc per kilo, 10 times 5 is 50. So really, any amount of dextrose multiplied by the cc per kilo, as long as it equals 50 to 100, is enough. Again, if the patient is hypoglycemic, I think it's probably good enough, and worrying too much about it is probably not worth it. In terms of the hyponatremia, again, symptomatic hyponatremia, I personally treat with hypertonic saline 3 cc per kilo. 3% saline, 3 cc per kilo. Obviously, we're all aware that correcting hyponatremia or hypernatremia very fast is probably a risk, but my understanding and my teaching has always been that if the patient is symptomatic with hypernatremia, I can give 3% saline as soon as possible. Once the symptoms resolve, in other words, if the patient was seizing, once the seizures stop, or if the patient had altered mental status, once the altered mental status stop, I stop giving the hypertonic saline and just give normal saline after that at maintenance. In terms of the hyperkalemia, again, I get an EKG now if I suspect hyperkalemia causing the patient to be ill-appearing to rule out arrhythmia, and I remind myself what are the EKG findings with hyperkalemia. And I think it's very important to realize that peaked T waves is unfortunately the sign that most of us remember, but it is the sign that is associated with mild hyperkalemia. I actually created a short video about the EKG changes of hyperkalemia, which you can find on the website to supplement this lecture. But it basically comes down to peak T wave, which we all remember, and then the rest of the changes associated with the hyperkalemia I think about as if someone is holding the EKG line and stretching it. So the second thing that happens is the T wave disappears. After that, again, as if someone is stretching the EKG line, the QRS becomes wider and wider to the point when you get sine waves. After that sine wave disappears, basically the patient can go into asystole and unfortunately die. So check out the video I posted in the episode show notes on my website, PEMRules.com, to better understand the EKG changes of hyperkalemia and hopefully remember them forever. Now, in terms of treatment, EKG changes or persistent elevated potassium, you really need to think about calcium gluconate, 10%, 1 ml per kilo over 5 minutes as soon as possible, and that can actually be repeated in 5 minutes if the EKG changes persist. And I think all of us know that calcium gluconate plays a major role in stabilizing the cardiac membrane and protecting the patient from the changes of hyperkalemia. However, I think it's also important to be realistic. Calcium gluconate is not probably something you can get in the emergency department very often. I gotta be honest, I don't necessarily remember the dose because it's not something I use very often, but there is a medication we all use all the time that can actually help out maybe just a little bit for the patients with hyperkalemia, and that is albuterol. Albuterol, being a beta agonist, can actually reduce the potassium level. I'm not sure that will resolve the hyperkalemia if the patient has EKG changes and symptoms from it, but it's something I can get in the Pediatric Emergency Department very quickly, and it's super safe. So remember, if you suspect hyperkalemia, you get EKG, and there are EKG changes, Certainly, treating it with calcium gluconate to protect from the side effects of the arrhythmia is very important, but giving albuterol is something you can do right away. Also important to keep in mind, you can give the patient what they actually need. So hydrocortisone is what those patients are missing and what's causing most of the symptoms. Giving hydrocortisone early can go a very long way. In terms of the doses, I try to keep it simple. If I suspect congenital adrenal hyperplasia in a newborn, I give 25 milligrams IV. In a child, 50 milligrams IV. Or if it's an adolescent who weighs like an adult, I give 100 milligrams IV. So in a newborn or a baby that is ill-appearing and I suspect congenital adrenal hyperplasia as the cause of it, I basically give 25 milligrams IV. It's probably not a great idea to think about the exact dose if the patient is ill-appearing from what I think is congenital adrenal hyperplasia. I've actually done it before, and giving hydrocortisone, again, if the patient doesn't really need it or does not have congenital adrenal hyperplasia, nothing bad happens. Moving on, in the differential diagnosis of the sick infant, we covered sepsis, congenital heart disease, and congenital adrenal insufficiency. The next thing on my differential diagnosis is metabolic disease, also known as inborn error of metabolism. Now, again, the further I am removed from residency and my general pediatric board, the less familiar I am with the metabolic diseases and their exact diagnosis and mechanism. I do try to keep in mind that for the most part, there are 4 that can cause the patient to be ill-appearing and are common, relatively common. Those are the urea cycle disorders, the organic acidemia, the glycogen storage diseases, as well as galactosemia. Now, again, trying to keep things simple, with inborn error of metabolism or metabolic diseases, I think about what will kill the child and I can fix it right now. With glycogen storage disease, it's really the hypoglycemia. With urea cycle diseases, it's the high ammonia causing encephalopathy. With organic acidemia, again, the acidosis or really the hypoglycemia, and the same with the galactosemia. So as you can see, there is a pattern here. With inborn error of metabolism or metabolic diseases, you really have to worry about hypoglycemia and fix it. And that is something we as emergency physicians can do and can do very easily. And that is why checking the glucose or AccuCheck or point of care glucose, whatever it's called in your facility, early is very, very important for those patients. You also got to remember that acidosis, hyperammonemia, and the possibility of sepsis is also an option with inborn error of metabolism. Now, with hyperammonemia, unfortunately, dextrose plays no role. The treatment is really focused on removal of the toxic ammonia with sodium phenyl acetate or sodium benzoate, which I must be honest, I've never given, but important to keep in mind. And again, never done it. If I truly suspect metabolic disease or inborn error of metabolism as the cause of the patient's illness, and indeed the ammonia level is that high, talking to the nephrologist for the possibility of dialysis early is very, very important. Going down the list, we discussed sepsis, congenital heart disease, congenital adrenal insufficiency as metabolic disease. The last thing on my differential diagnosis of a sick or ill-appearing infant is unfortunately non-accidental trauma. So non-accidental trauma, unfortunately, is more common than we all think. There are several risk factors that have to do with the patients or with the family dynamic or with the social situation, so I try to bear those in mind. Some social risk factors for non-accidental trauma are low socioeconomic status, unemployment or lack of education of the parents. Some family dynamics risk factors for non-accidental trauma are single parent, young maternal age, and parents who have multiple children. And the third one is the individual characteristics of the patients. Unfortunately, patients who were premature, have intellectual disability, or just under 4 years of age are at higher risk for non-accidental trauma. I try to keep those risk factors in mind given my differential diagnosis. With non-accidental trauma, the first thing I try to keep in mind is the injury explained? I think we all know the phrase, if you don't cruise, you don't bruise. If I see a newborn with what looks like significant head injury, obviously newborns or infants can't cruise and certainly should not have any significant head trauma. My personal experience is that abusive parents don't really know how knowledgeable we are and they would say something like the patient roll off the bed when the patient is actually just 2 months. And I know, as part of my general pediatric education, that a 2 months old simply cannot roll off the bed. And that is exactly why I tell the pediatric residents who study for the boards that the developmental milestones are actually more important than we think. And again, thinking about what will kill the child. Unfortunately, the cause of death for a child with abusive head trauma is not something I can really fix in the ER. It really boils down to increased intracranial pressure that is caused from intracranial hemorrhage, subdural hematoma, epidural hematoma, etc. I think it's also important to keep in mind the possibility of intra-abdominal trauma causing bleeding and maybe hypertension. And again, this is why CT head is on the list of those 5 tests I do on every newborn or baby that is ill appearing. Again, I do that as the last test because it makes no sense to me to send the patient to the CT scanner with hypoglycemia, hyperkalemia, or an arrhythmia, which is why checking the electrolytes and things like EKG come first. In terms of my evaluation for the possibility of non-accidental trauma, obviously CT head is the 5th test in the list, but I also keep in mind that skeletal survey for the possibility of rib fractures specifically will be very important. Other studies that are part of my evaluation for the possibility of non-accidental trauma is abdominal labs. If the ALT or the AST are elevated, that is a cause of a concern and is an indication for abdominal CT to look for those bleeding liver laceration. I also obtain a urine analysis looking for hematuria. If that's elevated, I suspect a kidney laceration and again order an abdominal CT. And if the lipase is elevated, same thing, abdominal CT to look for pancreatic injury. And that is it really. My differential diagnosis for an ill-appearing sick infant, as I mentioned, include sepsis, congenital heart disease, congenital adrenal insufficiency, metabolic disease, as well as non-accidental trauma. And when those are on my differential diagnosis, I keep in mind that I stat electrolytes knowing the sodium and potassium, as well as point-of-care glucose, chest x-ray, EKG, and CT brain go a long way, can really give you a direction and do what's best for your patient. So next time you see an ill-appearing baby or an ill-appearing newborn, remember those 5 diagnoses and 5 tests, and hopefully you'll be able to save a life. And that is it for today, guys. Thank you very much for listening. I hope you learned something. I hope you enjoyed the episode. Please check out the video I created to remember the EKG changes associated with hyperkalemia as a memory aid. Also, please check out the website, submit any feedback, sign up for the newsletter. I love hearing from you guys. Hope you like the outro. This is Pride by YouTube.